webinars that we've been hosting. My name is Catherine Chu, and I'm the director for the Center for Global Surgery in the Department of Global Health. And it gives my great pleasure to host this webinar on community participation in global health. And I would like to introduce my senior research associate, Ms. Lynn Bust, who will be moderating today. Lynn, thank you very much, and over to you.
Hi, everyone. Thanks, Catherine, and welcome today. So as Catherine said, my name is Lynn, and I'm a senior research assistant at the Center for Global Surgery. So very excited to be speaking to you today about this important topic, which is community participation in global health. So we have quite a packed schedule, and we'll be chatting to three very esteemed and experienced speakers. So Dr. Lucia D'Ambruzzo, Mr. Desmond Jimbaum, and Dr. Lydia Cancross. Unfortunately, our fourth speaker, Dr. Vuyiseka Dubula Majolo, is unable to join us today. She was unwell, so our thoughts are with her, and we're wishing her a speedy recovery. So a little bit about how the format of this will work. So each speaker will speak for about 15 minutes on their topic. And then after that, we'll have a panel discussion and a live Q&A session. So we ask that during the time that the speakers are speaking, that you keep yourself on mute, and there will be an opportunity for questions afterwards. But if you do have pressing questions that come up during the talks, feel free to post them in the chat, and then we'll monitor those and get to them during the discussion, which I'm really looking forward to. Great. So I think that's all the housekeeping, so we can get right to it. So to start, we have our keynote speaker, which is Dr. Lucia. So she is the Deputy Director of the Centre for Global Development at the University of Aberdeen. And today she will be unpacking the term community participation and the different meanings behind it, as well as expanding on her experience of participatory action learning in rural South Africa. So that's over to you, Lucia.
Thanks, Lynn. Let me try and share. Can you guys see those slides?
Yes, thank you, Lucia.
Yes, we can.
Okay, thank you. Hello, everyone. I'm honoured to join this esteemed panel today. As Lynn said, my name's Lucia. I'm based at the University of Aberdeen in Scotland, and I have a position also at the University of the Witwatersrand in Joburg. I'll be presenting work on community-led action learning in rural South Africa. And I'll talk to three aspects. I'll give some background, I'll outline the context that we've worked in, our methodological approach, and some learnings, primarily in terms of the process. So fundamentally, participation emphasises health as socially constructed, that is, as the result of social interactions. And the idea is that health and social systems can reflect harmful social norms, but they can also confront them. And from this position, those most directly affected by health problems, and particularly health inequalities, should be directly involved in action to address these. The underlying idea is that human beings are dynamic agents capable of reflexivity and self-change. And through community formation and solidarity, participation has goals of radical transformation and empowerment, and is a response to injustice. There's long policy support and recognition. For example, the WHO in 1978 identified participation as a key enabling mechanism for health for all. And there's been a resurgence of interest recently, with funders mandating things like co-production, community engagement and involvement, and nation states experimenting with participatory democracy, such as through citizen assemblies, for example. In practice, however, participation has variously progressed. Power hierarchies are often reproduced in participatory spaces and processes, resulting in tokenism, marginalisation, and exploitation, oftentimes in the name of participation. So despite long policy support, how to do participation is less well understood, and the fundamental category of power is drastically under-theorised. And the quotes here are supposed to reflect that policy and practice disconnect. We worked in a rural province in the northeast of South Africa, Mpumalanga, in the VAPOR programme, that's verbal autopsy with participatory action research. I'll talk to the PAR element mainly. The image in the top right of this slide is from Mpumalanga province, and it shows, as the Daily Maverick is reporting, the acute imbalance between supply and demand in the public health system that deals with a complex burden of infectious and non-communicable disease, maternal and child mortality, injury and violence that are disproportionately borne among Black, rural and poor population subgroups. While in the province and nationally, there's a major revival of the district health system and the bringing of services closer to people, there's a familiar contradiction. In practice, there are limited spaces for community voice and input. The second image there is from the rural sub-district in which we're based. We work in an established public health observatory, the Agincourt Surveillance System, which has a long-term 30-year presence in the area, covering a population of 120,000 over 420 square kilometres. The surveillance area generally encompasses rural villages. These are former homelands with multi-generational and multi-dimensional hardship. Practically, rural homesteads, for example, experienced limited piped water, underdeveloped roads, unaffordable electricity, and high unemployment. Agincourt data shows shifting public health profiles. While HIV-related and maternal and child mortality are declining, deaths owing to injury and violence and heart disease are increasing, as are multimorbidity and chronic illness. So in this context, this is how we organise the process based on a PAR, participatory action research cycle. Basically, PAR connects, validates and systematises lived experience with and for those most directly affected, taking action and learning from action. It's cyclical, it evolves incrementally, developing more context-specific processes over time. We work with local actors representing the community health system broadly constructed, so including women of reproductive age, traditional leaders, community health workers and others, to identify and address local health concerns and to do so together with the authorities. But we initially worked intensively in rural communities with the rural community stakeholders using PAR methods and tools to identify local health issues using listing, ranking and rating, building shared understandings of priority problems, their causes and consequences, and then shifting to a focus on action, mapping assets, actors, their influence and interrelationships, and drawing these together in action agendas, defining overall goals and stepwise feasible actions towards these. We also used a method called photo voice, where participants collected and analysed visual data, and there was regular interaction over many weeks and months, through which we negotiated and renegotiated principles of representation, voice and collective action. Analytically, the focus was on power and how power builds, responding to the lack of attention on it. And over a series of these cycles, we focused on how collective capabilities were built with rural community groups, but also how they were used. The idea being it's not just communities that need to change, the system needs to change too. And we drew on Jenny Pope's participatory power building, encouraging a balance between an inward and an outward gaze, and in terms of John Fox's work on social accountability, connecting citizen voice to state response, and from which we drew this metaphor, community voice needs teeth to have bite. So I'll share a few learnings. The first was really about how shared concerns connected health to other sectors and revealed major problems. In our first cycle, 2017 to 19, community stakeholders identified alcohol and drug abuse and lack of safe water as the most important health concerns locally. These are just some examples of the data and evidence we developed together. On the left are visual data. On alcohol and drug abuse, participants depicted unemployment, poverty, proliferating taverns as driving addiction, with multiple health and social impacts, and as these as self-sustaining problems, destructive of communities, and disproportionately affecting children and young people. On water, repeated and prolonged periods without piped water were documented, as were unreliable and unavailable infrastructure, inadequate service delivery, unregulated sources, empty reservoirs, and poor supply. These were more holistic framings of health issues grounded in community realities, and we supplemented on the right community intelligence with statistical data from the surveillance system. The gold line in this chart shows the high proportion of deaths in the site since it was established in '93. that could be attributed in some way to the community nominated priorities, showing a high burden of potentially avoidable deaths sustained over decades. So this initiated something of community voice through an articulation of shared priorities and the development of evidence on these. Community stakeholders guided us to bring in the perspectives of those most disproportionately affected by the problems identified and whose voices were most excluded. These were youth and adolescents and women of reproductive age. And with the expanded groups and with sensitive facilitation, managing expectations about the possibility of change, for example, we built the evidence and data, some of which shown in the previous slide. The process was designed recognising participants' ability to represent themselves and to direct the process, as well as nominating the health priorities, directing expansion of the participant base. Practical things like times and locations of meetings were determined by participants, as were the meeting proceedings. And participants reported gaining new skills and confidence through the process in things like public speaking, complex analysis. And we also observed a shift from individuals participating to more of a collective engagement, more of a togetherness. And the images here are supposed to reflect some of that. In 2015 on the left there, where we very first started, you can see a researcher standing, encouraging a participant to describe some visual data. On the right-hand side, by 2019, youth participants were leading these discussions here, selecting, systematising and appraising visual evidence. So these were our foundation to engage with the authorities, credible, actionable evidence and in parallel collective voice and capabilities. Representatives from the authorities then came together with community stakeholders to analyse these data and develop local action. We engaged across sectors with the Departments of Health, Water and Sanitation, Social Development, Culture, Sports and Recreation, the local municipality, NGOs and others. And again, with careful facilitation to build beyond blame to constructive dialogue, we had a further series of workshops where we collectively analysed the evidence and data and developed, implemented and monitored local action plans with the responsibility shared between participants. And these rebuilt a sense of community control over water and alcohol and drug abuse with shared ownership and responsibility between the authorities, the communities and the researchers. While we had mixed success with the local action plans, the authorities embraced the process as a platform to safely engage with communities without having to defend themselves and for multi-sectoral dialogue. And when we came to reflect on and refine the cycle, officials recommended its integration into formal primary healthcare governance at district level. So forging new relationships, mutual understanding and trust sort of gave the voice teeth, embedding community evidence into planning and action with the authorities. But the authorities didn't just take up the evidence, they took up the process. And this allowed us to combine an independent process with formal governance procedures, sort of combining claimed and invited spaces. And these relationships should not be underestimated. There are frequent violent service delivery protests in the area, especially over water. Our process indicated it was possible to shift these to more constructive dialogue and action. In 2020, as COVID took hold, we interrupted the next cycle and redesigned it to be of practical use as situations and demands changed quite dramatically. Both communities and the authorities recommended community health workers here as our focus, as the first line contact between communities and the health system, and their role in the early part of the pandemic was recognised by the government, who committed to bringing them into government contracts instead of subcontracting with non-profits. And we developed this cycle inclusive of a training programme to support community health workers to connect, raise and respond to local health concerns using rapid PAR techniques and facilitate action in communities, health systems and public services, and with community stakeholders from the prior cycle acting as mentors, sharing their knowledge and insight of the process. We learned that while they're central in the district health system reforms, community health workers in practice experience multiple challenges: lack of financial, logistic and health system support and training, lack of role clarity, insecure employment, low and no pay, poor safety and low status. Despite these, community health workers had remarkable resilience and commitment, especially in the face of COVID. The priority topic that was nominated in this cycle was people lost to follow-up in HIV/TB treatment, which was seen as a critical and potentially overlooked area as the service shifted to COVID responses. Local action plans were again collectively developed, implemented and monitored to improve access to information, treatment and care. And through the process, community health workers reported gaining new skills and competencies and forged new community and facility-based relationships and alliances. Their agency was visibly reworked as their competence and value were explicitly recognised at higher levels of the system as we engaged through the cycle. Again, at the end of the cycle, we reflected and collectively refined the process, and we're now rolling out in this modality beyond the surveillance setting throughout the sub-district with the Department of Health and with community health worker mentors, delivering a service component combined with a rapid research element. And our hope is that this supports the community voice with teeth to have bite. And what I mean by that is through the establishment of structures, opportunities and processes to rework agency in more empowered ways. So in summary, while community voice seldom features in public services, it was possible to create spaces connecting stakeholders to build dialogue, evidence, action and learning. The process needed time, space and a sensitive, inclusive, informed approach, shifting power and control to those most affected and with least voice, and adapting to changing circumstances and needs. Credible, actionable evidence and regular engagement beyond the health sector helped to develop new ways of thinking, collaborative mindsets and enabled uptake. So through the process, there were some gains raising community voice through more context-specific processes over time in those iterative cycles. The authorities embraced the process. There was formal recognition and uptake in other settings, which has helped give the voice teeth through these claimed and invited spaces combined. Achieving bite, though, is going to require a longer-term engagement, sustained connections, and with higher levels of the system. The problems surfaced aren't just local. In highly fluid contexts, this will be challenging. Nevertheless, the experience shows that regular safe spaces can develop and align community voice with state capacity to respond, a mutual empowerment that contributes to responses based on shared rights and responsibilities for health equity and social justice. To close with some reflections, PAR represents a major epistemological challenge to mainstream traditions. Researchers navigate conflicting worlds. The academy continues to reject paradigms, embracing plurality of knowledge and expertise from the margins, and quite correctly, communities question academics' contributions to their lives. Second, there's a major concern remaining about the under-theorisation of power and the potential for marginalisation within participatory processes. There's a real risk of hollowing of the concept and dislocation from its radical politics. We use this critique as a guiding principle. Participation is a form of power, and this must be recognised to avoid pitfalls and realise potential. In practice for us, this meant a commitment to self-reflection and critique. Third, on relationalities, there's a primacy of process. Participation is a simultaneous means and end, a process and a product. It's good to balance a focus on process with outcomes. There's quite a preoccupation around outcomes in public health research, quite rightly. But this necessitates specific research competencies and cultural sensitivities. We worked, for example, on not attempting to overcome our cultural difference, but trying to work with it and to share and progressively transfer power consistently. And finally, sustainability and sustaining the process over space and time is where we're at now. We are trying to understand how to reconstitute opportunities to reimagine agency in more empowered ways and beyond the lifetime of a research programme. For new community-based claims to health, ultimately through local action, challenging wider structural challenges. So it just remains for me to gratefully acknowledge the input and insights from community stakeholders, frontline practitioners, strategic planners, as well as from non-governmental and civil society groups, and of course, community health workers. Thank you.
Thank you, Lucia. I really enjoyed that talk, and I think you really highlighted some important points there. I think some of the things that came up for me were kind of participation as a form of power in itself, and that we don't just need community change, but systems change too. And I know that's something that's kind of being debated more and more. I think what else stuck out for me was also kind of the creation of safe and inclusive spaces in order to enable this change, and the fact that this doesn't really happen overnight, but kind of requires a lot of longer term engagement and takes cycles of learning and broader engagement. So thank you for that talk. I really enjoyed it and look forward to engaging with you more in the discussion afterwards. Just a reminder, if you have any questions, to please post them in the chat as we go. Otherwise, we will cover them all in the discussion. So now moving on to our next speaker, which is Mr. Desmond Jimbam. So Desmond is the Director for Health Policy and Advocacy for Operation Smile, which is an international NGO. And Desmond is originally from Cameroon, and he's an experienced researcher and health policy consultant, I think with nuanced understanding of current inequities in global health. So today he will be speaking specifically about his experience in global surgery and how grassroots advocacy can be used to build the network. So Desmond, that's over to you.
Thank you very much, Lynn, for that introduction. And thank you to the organizers at Stellenbosch University for this honor to speak with you all and about community participation in global health. So the title of my presentation is The Case for Grassroots Advocacy in Global Health. And I hope that by the end of this presentation, the case will be made, for why we need more grassroots advocacy in global surgery, why there needs to be a paradigm shift in where we focus our advocacy efforts. So I'm the Director of Policy and Advocacy at Operation Smile, which is a global cleft NGO that works to provide free surgery to children born with cleft around the world. So this is the outline of my presentation. We'll talk about this case, the case for global surgery. What is this case that we're talking about? What's the current status of global surgery? And then we'll review some of the initiatives that have been done, some of the accomplishments so far, as well as the gaps. And then we will also end with, highlighting and discussing why, global surgery advocacy needs to be centered at the grassroots. This was about 2 weeks ago at the World Health Assembly in Geneva. This is a panel that was hosted by the Global Surgery Foundation. And it's a side event of the World Health Assembly. And on this panel, very distinguished panelists. We had someone from the United Nations and from WHO, professor from Harvard, Atul Gawande from USAID, Smile Train, another cleft NGO, as well as a representative from Johnson & Johnson, which is a major funder from the private sector. And I did not attend this conference in person, but I followed remotely. And from what I could gather, one of the main consensus out of not just this side event that was discussing global surgery, the current state of global surgery and the case for it, but there were other side events. And the main conclusion was that the case for global surgery has been made. The case for investing in surgical systems has been made. So this was the conclusion, I believe, one of the major conclusions from this high-level event at the UN or at the WHO. And it kind of points back to this article that was written by Jim Kim and Paul Farmer. They were both co-founders of Partners in Health. And I believe that this article was one of the catalysts for the global surgery movement. It's an article that was written in 2008. And in that article, they famously referred to global surgery as the neglected stepchild of global health. And they called for surgeons and anesthetists and anyone involved in providing surgical care to step out of the operating room and advocate for surgery, highlights the burden that conditions like cataracts and, obstructed labor and trauma have in high-income countries and in low and middle-income countries. So they highlighted the burden, and they called surgery the neglected stepchild of global health. Fast forward to earlier this year at an event at the University of Global Health Equity, the two, Paul Farmer and Jim Kim, were asked whether global surgery was still the neglected stepchild of global health. And Paul Farmer said, no, to quote him, he said, "I'm delighted to tell you that you have lost your title as the neglected stepchild of global health. We now see that surgery is the most exciting part of global health equity." So Paul unfortunately passed away just a few weeks after he made this declaration. But he was a huge advocate for surgery, in spite being an infectious disease doctor. But the point here is that there seems to be a consensus that the case has been made. And for those of you who are not aware of the global surgery literature, let's look at what that case is. So one of the landmark publications highlighting the case for global surgery was this Lancet Commission on Global Surgery. It was published in 2015. And it highlighted a number of things, but it had 5 key messages. The first key message was that 5 billion people around the world lack access to safe, timely, and affordable surgical care. And what this means is that, if, for example, your child, gets hit by a car or something and has a broken femur, to access surgical care is a challenge. Number one, there are a number of obstacles that you face. Now, it's finding a hospital that has the capacity, the surgeons, the staff space and systems to heal that femur. Number 2 is getting to that facility in a timely manner. That's a barrier because many of the facilities are quite far away, especially from rural communities. And number 3 is, even if you're able to get the care could still be very expensive and impoverishing, so it could lead to poverty. So that was one of the key messages. 5 billion people lack access to surgery. They also found that in order to address the current burden of surgical conditions around the world, 143 million additional surgeries were needed each year. And the majority of this were surgeries that needed to be done in low and middle income countries, right? So even though the burden of surgical conditions are highest in low and middle income countries, the least number of surgeries were done in LMICs. The third key message was that 33 million people face catastrophic expenditure every year from seeking and receiving surgical care. So just having access could lead people further into poverty. And then the fourth message was that investments in surgical and anesthesia services is affordable, save lives, and promote economic growth. This was an economic argument to say that by not investing in surgery, countries are losing significant percentages of their GDP from the loss of productivity, especially from the younger generations, the younger people that are affected by surgical conditions. And finally, this was a quote from Jim Kim, who was the president of the World Bank at the time. And he said, surgery is an indivisible and indispensable part of healthcare. And, this key message was to highlight the fact that for the longest time, surgery had not been considered a part of universal health coverage and should be. There have also been cases that have made for the utility of surgical care to addressing the Sustainable Development Goals. This paper points to the fact that up to 8 of the Sustainable Development Goals could be addressed by strengthening surgical services. So surgical services will contribute to attaining 8 of these Sustainable Development Goals. Since then, there have been progress from a policy perspective from countries around the world, particularly in sub-Saharan Africa, to develop what were policies called National Surgical Obstetric and Anesthesia Plans. And these are quite, well-crafted plans, in my opinion, that assess the barriers and the capacity and the inequities of surgical care in a particular country. And the stakeholders decide what priorities should be addressed from a workforce perspective, how many surgeons need to be trained, the infrastructure that needs to be rehabilitated. So they look at all these kind of comprehensive, holistic aspects, and quite a number of countries have developed these policies in Africa and Southeast Asia. Yet, can we really say that surgery is a priority for policymakers? There have been limited resources that have been allocated to surgical care and policy implementation at all levels, at the national level and at the international level. And can we also say that surgery is a priority for the general public? Is this something, this is a question, right? Is this something that is discussed on local radios, on local TVs, or even by the communities that are most affected by the surgical conditions? And national surgical plans, I believe, right now, many of them, or most of them, are sitting on shelves and they're not implemented. So why is grassroots advocacy needed to address this problem? Again, the conclusion from the WHO was that the case for surgery has been made. And to that I ask, to whom? The case has been made to whom and by whom, right? If we're talking about the academic communities and the international communities, then perhaps, the case has been made. But at the local level, at the national level, I'm not sure about that. I don't think the communities have been brought in, the communities that are significantly affected by surgical conditions, and the families and the frontline healthcare providers who deal with surgical conditions in very dire situations. So this was the basis of a paper that we published in BMJ Global Health. And we make the case that politicians are accountable to their constituents. It's important, I believe, to do the international advocacy and to talk about these things at the WHO, but ultimately, those ministers of health, those politicians, are accountable to their communities, to their constituents, and the constituents are the ones that need to be at the center of advocating to their politicians, to the policymakers, for the prioritization of national surgical plans or prioritization of surgery. Otherwise, we end up with plans that ministries of health develop in consultation with external experts from the WHO, from academia, but they don't get implemented. As Dr. Lucia has highlighted in her presentations, the communities are powerful change agents. Those that, suffer, those that deal with the consequences of lack or poor quality surgeries, they are powerful agents for change, and they should be brought to the center of the conversation. I also think there's a lot that we can learn from the other movements like the HIV/AIDS movement, where patients and HIV, families and communities that were affected were on the streets, they were protesting, they were demonstrating for more research, they were demonstrating for governments to invest in medicines, invest in making those medicines cheaper, right? So I believe that the global surgery community can learn a lot from other movements, even the maternal health movements in terms of grassroots advocacy. These are just a few strategies that the global surgery movements or the global surgery community, can consider in terms of grassroots advocacy. And I don't have time to go into detail, but these are some ideas. For example, building coalitions and having public demonstrations. These are ways of getting the attentions of policymakers to really address the issues beyond developing plans, beyond passing resolutions, but to put their money where their mouth is. There are some challenges, a few challenges that I think the global surgery movement has to consider in terms of grassroots advocacy. Right now, I believe there are a few grassroots advocacy organizations that are really focused on advocating for global surgery. And so there needs to be additional support to the organizations that do exist, supporting local champions. And I think there are patient advocacy organizations in many countries that could be brought in to be part of the conversation and part of the efforts. I also think that one of the challenges of surgical conditions is that they're non-communicable. And so it's really a challenge to get policymakers sometimes to address this, unlike something like COVID, which transcends borders and which transcends individual communities. So this is a challenge that we have to think about in terms of messaging. But surgery itself is not a disease. It's a modality of treatment that encompasses several diseases, and so we need to find ways of unifying our messages. So these are a few things that I think we need to do. Learn from other global health movements. We need to develop a unifying global surgery advocacy messaging. We need to support and train local champions and grassroots organizations. Advocacy is not really something that is taught in most medical schools and even public health schools in many countries. And so even if surgeons and anesthetists want to advocate, they may not have the skills to do that at the grassroots level. So I think there's an opportunity to provide that training for how to set up coalitions and publish op-eds and get the attention of policymakers. I also think that global surgery academic programs that are based in LMICs are needed to conduct research that is relevant, that will make a stronger case at the grassroots level. So thank you very much. These are a few references from my talk, but thank you so much for this opportunity, and I look forward to the discussion.
Thank you, Desmond. Sorry, is there a bit of an echo? Is it just from my side? Okay, I think it's better now. Thank you for that presentation. I think giving us a bit more of an explanation about what global surgery is and kind of outlining why grassroots advocacy is missing but so crucial to global surgery. Yeah, I agree that I think we can learn a lot from other global health networks, such as the HIV and Maternal and Child Health Network, and maybe we can unpack this a bit more in the discussion. And I think, yeah, although the two speakers we've had are very different topics and different settings, I think the common theme between these two talks is that the most powerful change agents are those most affected, which is your point, Des, particularly those that are marginalized and vulnerable, but they're often overlooked in global health. And I also really liked your last point, kind of that advocacy isn't taught, so we don't really understand what it is or how to actually do it, even though it's a word that's sometimes used. So I think that's something that we can definitely elaborate more on. Thank you, Desmond. So moving on to our last speaker, which is Dr. Lydia Cancross. So she is the head of general surgery at Groote Schuur Hospital, UCT, as well as an advocate for People's Health Movement. So she is an activist and a surgeon, and today she will be speaking about how to enhance the agency of activists, academics, and community leaders in order to advocate for access to surgical care. So Dr. Cairncross, that's over to you. I think you're still on mute. Oh, it's still on mute. I don't think we can hear you.
Hi there.
There we go.
Okay, great. And can you see my screen?
Yes, we can see it.
Okay, excellent. So thank you very much, and thank you for the kind introduction. And actually, it's interesting because I think the talks really flow together quite nicely. And I've been thinking a little around which aspects to focus on with today's talk. And it's interesting that Desmond ended with a comment about teaching advocacy, because I'm also part of the Division of Global Surgery at UCT, and what I teach in the courses is the advocacy section. So I'm going to comment a little bit about advocacy. I'm going to comment a little bit about what we do in the work that we do within the surgical sphere, and how I think that connects to the broader health discussion. So when we're thinking about advocating, and this is focused on surgical care, but obviously it relates to all forms of care, we're looking at a pathway of care, and every single part of this pathway needs intervention and it needs change. And the real purpose of advocacy is to be a catalyst for change. And in the global health, and specifically in the global surgery arena, we're talking about catalysts for changing what the health outcomes are. And this means that we need to bring society behind the cause of improving health and health systems and healthcare. So these are a few slides from my advocacy teaching, and I always find this interesting. I ask the people in the room to tell me what they think advocacy is, and what does it look like. And then these are the different kinds of options that I like to speak to. So advocacy could be lobbying government around a particular policy. It could be newspaper articles or op-eds, could be petitions, although we don't do them on paper anymore. For the academics, academic presentations at conferences is a form of advocacy. And then there are the other forms of advocacy that come to mind when we think about mass mobilization, such as pickets and sit-ins and protest marches. And when we're thinking about how to change something, how to make the reality of today different to what it was yesterday or what we would like to see tomorrow, I think you actually have to take a way to be systematic about advocacy. And even though this is a circle, thinking about which part of this process you're contributing to is important. So we need to understand the problem, and that's where our researchers come in. We need to identify solutions. Sometimes those are real world, and sometimes those are also research generated. Then we need to make noise about it, which is raising consciousness, writing articles, using loud hailers, going on marches. That's raising consciousness. Policy for me is about changing the rules, which I think as academics we are very engaged in that space and effective in. But the fifth step, which is building the movement, is I think where advocacy often falls down, because if we don't have a movement to generate this change, it won't actually happen. So this is an example that I give to show why we struggle with implementation. So I was involved with a task group with the Department of Health to develop guidelines for early diagnosis of breast cancer. And it was very exciting. We had all the right people in the room. We had academics from the various universities. We had a research base to work from. We understood the problem. We knew why we needed to have earlier diagnosis of breast cancer. And we had some solutions identified already. We knew what worked in the real world. There were examples out there already. We also had consciousness within the academic community and within the government space about what needed to be done. So we didn't need to do a lot more of raising consciousness. So we wrote a beautiful policy, the new breast cancer policy, and that was in 2018. And it has not changed how breast cancer is diagnosed and treated in South Africa at all. It hasn't resulted in a change in women's actual lives. And I think this gap between policy and implementation is one of the biggest issues that we have in South Africa and obviously in other parts of the world as well. So we have really good, comprehensive, often well-written policies and guidelines with a launch and a document and often some media fanfare around it. But on the other side, where the implementation needs to happen, often the primary care providers are not involved and they're not told about the policy, they're not informed, they haven't been involved in drafting the policy. The users of the health system are not aware that, for example, if you have a breast lump, you have the right to be seen within 3 months at a breast diagnostic clinic. People do not know that, so they do not demand it. And at a systems level, even if people did know that and went, the clinics don't exist or they're under-resourced or not properly equipped to do the work. So we need to actually build a community or a movement within the community to shift practice and to shift power to make it actually happen. And as clinicians, we interact with the health system in this sort of diagram. So you have clinician and patient. Those are individuals interacting. And beyond that, there's the hospital and the family. And then beyond that, the health system and the community. So there is that connection. But it's really at that intersection between the health system and the community that we don't have enough input, enough agency, enough focus and mobilizing happening. And because of that, we have a lot of knowledge and thought about what we think should happen in the health system as academics and clinicians, but we have very little understanding of what the community experience is of the healthcare that we are providing. So when I think about community involvement, so my first question is, who's the community? So there's 60 million people in South Africa. If we're thinking about the community as bounded by national borders, which of course is also up for discussion, what does that actually mean in terms of how you connect with people in a structured way? So we know a significant proportion of the population is in school, many parts of the community is involved or organized within social movements. And I really liked Lucia's allusions to participatory democracy. We don't have participatory democracy in South Africa. So in a sense, we have to build it. And for me, the place that we build it is at this intersection between the health system and the community, the broader community. And at that intersection, from my current experience and knowledge, I think there are 3 key role plays that we need to intersect with. Those are community health workers, health committees, and health forums. Now, community health workers, there are 70,000 community health workers in South Africa, more or less. Most of them are employed by NGOs and NPOs. They are not integrated into the health system. They are not recognized. They're not on the PASAL system of the Department of Health. They're underpaid, as Lucia alluded to. This critical connection between us and our broader community as a health system is completely undervalued and under-recognized. So I think if we're going to be advocating for change within the health system, we need to be fighting for community health workers. The second key role player in this intersection are the statutory bodies that have been established by the Department of Health as representative of the community. Now, we can talk for a long time about problematizing how these are functioning, how they work, and it speaks to how the power relationships are played out again within these structures. But health committees should exist at every single health facility within this country, and there are about 4,000 of them. They should be nominated and elected by their communities. We know that in the Western Cape, they are nominated by communities, but appointed by the MEC. And they should be a formalized representative voice of the community and the experience of the health system. And then lastly, health forums, which are broader than health committees. And maybe during the Q&A, we can talk a little bit about health forums. But health forums are not just representatives of health committees, but also all structures within the community that are engaged in health in some way. So that could be a youth group. It could be a church mobilizing around food and quality nutrition for children, etc. So I want to give you an example of why I think this interface is important and how I think we as academics and clinicians need to start thinking with an open mind and listening with active listening processes. So within the People's Health Movement and within Global Surgery, I've been part of conducting community engagements where we have mutual learning. So in this slide, you'll see on the one side, we've got one of our clinicians, Tracy Adams, who's teaching about cervical cancer. And on the other side, we have Marion, who is a health committee member from Manenberg, teaching us about what's happening in that community in terms of how they understand cancer, how they interface with the health system, and why it is that people may or may not come with their symptoms. So we came in wanting to talk about cervical and breast cancer, and we ended up talking about the HPV vaccine. And the conversations from this one series of workshops is going to help someone like Tracy input into policy discussions around the HPV vaccine. And our input from the clinical academic side is inputting into community campaigns. So how many 9-year-old girls are actually being vaccinated? What is the attitude of school governing bodies? Why is there no real partnership between the Department of Health and also and the Department of Education on this issue? And from this, we're thinking, okay, so I can see a campaign, I can see a public engagement media, social media, radio, etc., around why the vaccine is important. But we can also see there's academic research that's required here. What is the current reach of this vaccine? What are the community attitudes towards it? And so on. So you can see that it's at this very vibrant interface within the community that we need to be doing our work and referencing against it all the time. Because when we do that, we're learning, and we are learning what the correct questions and answers are for the work that we might be doing at academic level. So in conclusion, I think that change is about knowing what we need to do, yes, but it's also about generating the power to make it happen. And that power doesn't sit in one particular place. It sits with all the role players, with the academics, with the clinicians, with community leaders and policymakers. And those role players are interchanging their roles all the time, because there are times where community leaders are producing the research that are answering the questions or asking them. There are times where clinicians are the community leaders or the academic or the activists. And there are times where the policymakers are coming from non-traditional spaces. But we have to have all of those people engaged in that interface. And for me, how I see at the moment what we need to be doing in terms of building health advocacy in this country, I think we need to be consciously supporting in our work, in our programs, in our writings, the work of community health workers and their recognition and advocacy for them as workers. And secondly, we need to be building the structures of participatory democracy at the health facility level, because then we have an established health leadership that is part of this broader health leadership, and we join that. We don't have to recreate it every single time we have a health issue that we want to take up. So thank you very much. Okay.
Thank you, Lydia. I think ending with some really important points there. I think that gap between policy and implementation is really crucial, and kind of how we can look at that interface and make change there is really important. And I think especially in South Africa, I mean, if you think about how stakeholders are not involved in the policy making process, and then how that implements that policy actually being rolled out. I mean, one good example coming up is the National Health Insurance, which is going to affect every aspect of health. And I think it's a really critical point to think about. I really liked your point on building participatory democracy between health systems and community, and that I think that's something that's come up with Lucia's talk as well, and with Des, is that community health workers are really crucial in all of this, and they kind of are at that interface. So we need to fight and advocate for them. And also your points at the beginning, I think, about being catalysts for change and kind of figuring out how we can all make noise about it and raise consciousness together. Great. So thank you for that talk. I really enjoyed it. I see we've got some questions coming through, which is great. But now is your opportunity to ask. I think if you've got anything that you'd like to post in the meantime. Otherwise, Catherine, would you like to say anything before we move over to the discussion?
Yeah, just to thank all our speakers. It was like a fantastic presentations, and I'm not often at a loss of words, but I think there was so much to digest there. I think maybe I wanted to kick it off by asking Lydia. I mean, Lydia, you mentioned quite a number of stakeholders, community health workers, but as you say, a lot of them are funded by NGOs, which is sort of frustrating because I think, like we've got a project with some community healthcare workers funded by an NGO, but you wonder how sustainable that is if they're kind of separate from government. So maybe the larger question is, what responsibility or role do you feel like the provincial health department should be taking in this idea of creating more of a movement around health issues? And again, not specifically about sort of surgical problems, but as you say, setting up the structure. So you mentioned, the health committees, which I know in the Western Cape are fairly active, but I even wonder how much agency do these health committees help feel that they already have? I think that when Lucia does PIR, they're really asking the community, like we want to know, but kind of on an everyday basis, speaking up and being more proactive. And then, how much responsibility or should we throw back at the province health department? Because as clinicians, we work for them, but, it's because you showed that picture of clinician and patients as the interface. And we do have a special relationship with our patients one at a time, but, not to put the responsibility off on government, but like, where are they?
Yes. Do you want me to come in now? Yeah, no, Catherine, thank you for that question. That's at the crux of it. So lots of valid questions here. So the first one, what is the role of the Provincial Department of Health and National with community health workers? So for me, this is like a labor outrage. I mean, it makes me so angry every time I talk about it. So community health workers, lauded as they have been for their work during COVID, need to be paid a living wage. They need to be employed as health workers formally, permanently within the health system with an accredited training program and a job description. It is a complete outrage what is happening at the moment. So NGOs have played a huge role in helping in many ways, so around HIV, around home-based care for various problems, but the community health worker space is not organized properly into the health system. So we need the Department of Health to insource community health workers. That's what I think on that. Then with regards to health committees, and I'll just comment briefly to give others a chance. So it is true, setting up a structure on its own is not enough. So you need a representative body, but it needs to be a representative body that has the agency and the space to play their role. And that's where the provincial departments and nationally need to, first of all, promote and support democratic practice, which they don't actually at the moment. So, I mean, appointing the committee, is a big problem. But in many parts of the country, there are no committees. So they're not supported and promoted from the Department of Health. And then secondly, and I think this is where our role comes in as clinicians and academics, so to ask the right questions. So if a health committee member has got a mother who had stage 4 breast cancer because it was missed for X number of months, they need to actually have the breast cancer policy in hand when they go to their facility and say, why was my mother not referred? Why did she not have a biopsy? And that's where we come in and say, hey, do you know that all 9-year-old girls are supposed to be vaccinated against HPV? And that's the exciting interface. So we need to support the establishment of those committees and then support their ability to actually hold the facilities accountable in not necessarily a confrontational way, but in a supportive way, because it makes the whole system better. So I'm going to stop because I can talk a long time. So.
Thank you, Lydia. Lucia or Des, do you want to respond to that at all too, or can we go into the other questions?
I would say quickly to leave space for the other questions. I can see there's a lot. I totally agree, Lydia, with what you're saying. It's kind of tragic, isn't it? Community health workers are the key, are the answer to connect the people and the state, and they are recognised in primary healthcare re-engineering, shift to universal health coverage, but the policy and practice gap is huge. International evidence suggests that a combination of these, I was talking about these claimed and invited spaces, so absolutely those formal mechanisms and processes need guidance, they need regulation themselves, because there's danger of elite capture, as I was trying to say, within participatory spaces and processes. They can be co-opted quite easily, and there's a lot of evidence to suggest, and quite recent evidence, and not only in health, also in participatory water governance. Similar things are seen whereby these spaces are co-opted. And international evidence is starting to suggest that a combination of claimed, i.e. bottom-up, grassroots, independent, and formal, invited spaces can be the key to enable that element of, independence in a more flexible, inclusive, accessible way, to include those who might otherwise be excluded from spaces that might be more prone to elite capture.
Thanks, Lucia. I think those are some good points too. Okay, so we have about half an hour to go through all of the questions and kind of have some discussion around. I think there's so much that we can unpack further with this. So I see there's 3 hands up at the moment, so I'll let those 3 ask their questions first, and then I see there's also some questions in the chat, so we'll jump to that. So if you have a question, you can either post it in the chat, or if you'd like to speak directly, then you can just put your hand up and we'll get to you. So starting with Sibangani, would you like to unmute yourself and ask your question?
Okay. Good afternoon. Can you hear me?
Yes, we can hear you.
Yes. First and foremost, thank you so much for this very wonderful presentation. This morning when I woke up, something told me I think I should become an advocate. Little did I know that the entire presentation will just focus on that. My question perhaps is, having done this presentation, is there a forum where we can engage further in consolidating these ideas, capacitating people, especially with issues to do with community engagement and so on, because the literature here and the presentation is quite rich. And also seeing that most of these presentation also focus on the health aspect, which is under the Ministry of Health. From your experiences elsewhere, is there flexibility to accommodate members of the public who want to be advocates? Because most of them, they have to come through NGOs, community-based organizations, and some countries, ministries are very hostile in working with NGOs. But how do we make sure that there is an approach that makes sure that people really play an important role? Thank you.
Thanks, Sibangani. I think that's a good question. How do we all become advocates? Is there anyone of the speakers in particular who would like to answer that? Maybe Des?
I can give a few thoughts based on my experience in global surgery. I think we all need to become advocates. We're all advocates in some way in our lives, you can think of a child who's trying to advocate for the parents to give them more playtime, and you have to come up, the child has to come up with the arguments and all of this. I think we all have advocacy in us because we all have cases that we're trying to make to different people who are in positions of power. But I think that there is, like I mentioned in the presentation, a certain skill to doing advocacy well that is lacking, especially in the global surgery space. There's we're calling for surgeons and anesthetists and nurses to step out of the operating room and advocate, but many may not have the skills that Lydia mentioned in her presentation about, how do you mobilize communities together? How do you, form coalitions and identify people with like-minded, goals? So there is a need to do that. And so I believe that the global surgery community, we need to start coming together. Lynn and, Catherine, I believe you guys are, organizing AfroSurge in September, which will really focus on grassroots and participatory research around global surgery. And I think more of these types of initiatives are needed. With regards to the second question, it really varies from countries to country. There are countries where, people can be a bit more, I guess, confrontational with the governments without fear of, losing their lives or losing their jobs. But in other countries, that's not the case. And so in every country, I think you need to assess which type of advocacy is most impactful. Sometimes we say write op-eds, but sometimes people don't read the op-eds. Op-eds are not as powerful in some instances as they are in other situations. So I think it's probably on a case-by-case basis. You need to evaluate what type of strategy would be most impactful, whether it's a coalition, whether it's op-eds, whether it's media engagement, or even social media. That's a very powerful way to engage with those in these positions of power.
Thanks, Des. I think a great point that we are all advocates already in our own lives, but that also different skills are useful in different settings. And yes, that's right. Catherine and I are busy organizing the AfroSurge in September, which will focus on grassroots advocacy and global surgery. So really looking forward to unpacking that more there. Lydia or Lucia, would you like to respond to that point too? Those questions, otherwise we'll move on.
Yeah, it's true. I mean, if you're working in the health sphere and you are seeing a problem that you're trying to solve, you're advocating for change. And I mean, to the person who asked, how do we bring this all together? We are bringing it all together in different forums, but I think it is important to find the issue that moves you. So, within surgery, within global health, there are so many things that you can take up. And I think finding the issue that moves you gives already a kickstart to energy. Secondly, what's your sphere of influence? So I'm also involved in a campaign around child hunger because it makes me weep. But I don't have as much agency. I don't have as much platform in that space as I do within the surgical space. So I'm engaged there, but I'm not leading in that space. I'm participating. I'm signing the petition. I'm going to the meeting. But in surgical care, I'm leading on surgical recovery because that is where I have influence, and that's also what I'm passionate about. And so, for example, a journalist has influence in the writing sphere, and sometimes an op-ed can make a big difference. At Livingston Hospital, they didn't have implants for fractures to orthopedic surgery for weeks, and they've been struggling. And the Daily Maverick published an article on it 2 weeks ago, and a week later, it was such a shameful thing. There was an emergency meeting and something, and suddenly the tenders are being signed off, and they're now starting to do some of those operations. Now, you might think that's one hospital, one department, but for those patients, that makes a big difference. So advocacy also doesn't have to be for every single issue, something that changes the whole world. It can change the thing that's in front of you as well. And even as an individual, what you are doing one day might be this thing that's in front of you, and another time, another phase of your life might be a big world-changing thing. Yeah.
Thanks, Lydia. I think those are really good points. I think, yeah, what's coming across is it's totally different in different settings, and you kind of have to. I really liked about finding what really drives you too, because I think that's very relevant in my own journey, and I think a lot of people can probably relate to that. So thank you. Moving on to the next hand, Irene, I see you're next. You want to unmute yourself? You can go ahead and ask.
Good afternoon, everybody, and thanks to the team for putting this together. It's really interesting. It's very important that the discussion around community volunteers and payments has been mentioned in this forum. And I'm asking this question in relation to the community participation approach. From my experience in working in the health system in Ghana, we've had programs that has worked with community health committees and community volunteers. And so my question is around this. In terms of selecting people as community health workers or community volunteers or advocates, there has been two models that have been employed. In some situations, community leaders come together, identify who the community is comfortable with, and select these people as community health workers or community volunteers to work for them. In another model, NGOs who have worked in these communities over a long time have identified individuals, and then the NGOs select these people themselves to be volunteers or community health workers. Now, talking about sustainability, payments of these community health workers and volunteers, I wanted to ask, in your experience and in your practice, which of these models are more sustainable in terms of regularizing the job of these workers and getting them salaries? Thank you.
Thanks, Irene. Sorry, I might have missed that. Was that directed towards a specific speaker or?
It's directed at the first speaker and the last speaker, because they both mentioned community health workers and
fantastic.
volunteers. Yeah.
Thanks, Irene. So Lucia, would you like to go ahead first?
Thanks, Irene. I think it's a really important point, and there are no simple answers. You know, the way by which community health workers, which we can all agree in theory are massively important to address the social determinants of health inequalities, the way they're recruited, remunerated, etc., needs to change to something more sustainable. And I think, Irene, you used the word, what's most sustainable? I don't think I have any personal insights into whether nomination through traditional leadership or NGOs have relative merits over one another, but I would advocate very much along the lines of what Lydia was talking about, and Des to an extent as well, that this cadre of worker needs recognition, resource, support, training, pay, pensions, sick pay, etc., all those other benefits. And for me, as I was saying, in that kind of tragic way, community health workers embody that disconnect between near ideal, progressive, inclusive, pro-poor policy, but its implementation is a very different thing. So while I have no particular insights on the relative kind of merits of traditional leader recruitment versus through NPOs and NGOs, I would say probably along the line of the spirit of primary healthcare re-engineering and the revival of the district health system needs to come from the ground up. And those needs and requirements to get that sustainability that you were mentioning need to be determined by those at the sharp end, right? By community health workers themselves. Some of the community health workers we've worked with in the VAPOR programme have not had payment in 5 years. So when I talk about resilience and commitment, you know, that goes beyond, it needs urgent attention, and basically, as I say, I think that needs to come from the bottom up would be my view. Thanks for the question.
Thanks, Lynn. By the way, can you see me? Okay,
yes,
okay,
I can see you.
okay.
Yeah.
So I think we need to distinguish between community health workers who are actually working for the health system. So they're distributing TB medication, they're taking blood pressures, they are they're checking up on, they're helping with wound care for bedridden patients. So they're actually doing work of the health system. They're just doing that work through a labor broker. Sorry, maybe I shouldn't say it that way, but they're doing it through NGOs and NPOs who are very well-meaning and are often very good, but it means that they get paid stipends and they don't have job security. So those are health workers. I think that's different from the question of representativity, community representativity at health facilities. And I like your distinction between claimed and invited spaces. Lisha, lots of words I've learned today. So the health committees are statutory, and those are mostly voluntary. And that, I mean, you can debate the pros and cons of that, because we are dealing here with a wildly unequal society and very impoverished communities. So when you bring remuneration into representativity, you bring a whole different political discourse. So this is not people, these are not people that are going home to home and delivering health care. They are representing the interests of the community at the interface with the health facility, which is a different role. So there, I think the discussion about volunteerism versus remuneration does come up. But there's a third level, which is the claimed space. And for me, those are what in the Western Cape are the health forums, but in other places will be different. So the health forums are not recognized formally by the health system. They're not appointed by the health system. They are the people in the community who've stood up and said, we are interested in healthcare. So these are like the school walking buses that help people to go to and from different parts of the community to keep people safe. They will be part of the health forum. They would be Sonke Justice, for example, or social movements. And they actually can hold the health committees accountable. I hope I'm making sense, because it can be quite a complex space, but that's why I have those three. And those are the three that I think at the moment from my listening, but I'm open to continuously learning because I need to learn in this space. So there are health workers who should be employed by the health system. There are health committees who are recognized by the health system as formal representatives. And then there should be health forums or a kind of community structure that are independent and are more political actually, and hold those other formal structures accountable.
Thanks, Lydia. So kind of different formats and different sectors, and I like the point on holding each other accountable, because I think that's also an important thing in this space, is that we all need to do that and always learning and growing from these things too. I think it's great. Prof Geiger, I think is am I pronouncing it correctly? If you want to unmute yourself, thanks for your patience, and go ahead.
Good afternoon. And my name is Martha, by the way. Thank you very, very much for a profoundly interesting afternoon and well-prepared sessions. This has really been insightful and interesting. I have a question about the nature of advocacy. And there are so many different kinds of advocacy, but the one that I was missing, and I just want to fill in, although I'm more in a general rehabilitation environment now, I come from a background in speech therapy, including work with children with cleft palates, etc. And so this question is based in that environment. And my question is the value of advocacy, or the value of long-term outcomes of surgery as an advocacy tool. I mean, and if I may, Desmond, just jump in, because I mean, SMILE is such a well-known organization with wonderful outcomes, etc. And a lot of the advocacy there happens through the photographs that happen soon after surgery. But I think that sometimes there's also a disillusionment in communities with the long-term outcomes of a surgical process if it happens in isolation and if the rehab aspects don't follow on. So I was delighted, Lydia, in your presentation to see that slide with all the different elements and the rehab being part of the program. But I think that just in planning advocacy and so on, that could be highlighted or emphasized more as a need of the process, because the surgery on its own is so often not the whole story. And sorry, it's a hobby horse of mine just to emphasize that, because I've seen the long-term disfigurements and frustrations and so forth of families who've had exposure to a miraculous surgery, but then years later, that same child or young person in the meantime is struggling with immense dental problems, speech problems, hearing problems, because the follow-up didn't match the surgical process. So I guess I don't quite know what I'm asking, except to just to raise this concern, and whether in fundraising and advocacy that could be highlighted more is my request, I guess. Thank you.
Yeah.
But thank you.
Thank you, Martha. And I wholeheartedly agree with what you're saying, that we ought to be highlighting the long-term benefits of, in the case of cleft, right, comprehensive cleft, that it's not just the before and after the surgery, the pictures, what is immediately visible, but there are long-term consequences that needs to be addressed with things like, speech therapy, and other additional kind of orthodontic and types of care. And I actually do appreciate this because I personally have had to deal with the consequences of surgery. I broke my femur about a year ago and had the surgery. It's a whole long story there. I had an infection after the surgery and had the additional surgery redone and another infection. But beyond the surgery that I got, I realized that the physical therapy was a huge part of the care that I needed after my femur reduction. Because even though the surgery helps significantly, I may not be able to walk or run if the physical therapies are not there every day holding my hand and supporting. So I do agree with you that we have to advocate for comprehensive care, not only emphasize the surgery itself. And I think that's the value of bringing all the stakeholders to the table, making sure that the speech therapists are involved, the nutritionists are involved, the dentists are involved, the psychosocial counseling that is needed, because there are also mental challenges that many, in this case, cleft patients face even after they've received the primary or secondary surgeries. So I wholeheartedly agree with you, Martha, and I think when we have these community participation kind of forums, we need to make sure that everybody is at the table and we come up with comprehensive solutions and policies that not only look at the immediate treatment, the surgery, but looks at the long-term care that the patient will need to be properly rehabilitated.
Thank you, Des. I think surgery is a good analogy for the whole health system, where you need a multidisciplinary team to care for you post-surgery. You also need all the different stakeholders involved in the health system. So we've got 5 minutes left, so I'm going to jump to the questions in the chat quickly. If you've got any more pressing questions, and please feel free to raise your hand or post them in the chat now. Otherwise, thank you, Dr. Nyasulu. I know you posted your question quite early on. I don't know if I think you posted 2 questions actually. If you would like to unmute yourself and ask the question in person, otherwise I will read out your question. Give you a second to respond.
Okay, thank you so much. Thanks, colleagues, and thanks to the presenters for the great presentations. My question is regarding community participation and demand creation. Actually, the 2 questions are talking to the same thing. I've had experience from some sub-Saharan countries like, Malawi, Mozambique, where there are systems where the communities, not through the community health workers, but the communities themselves, using stakeholders, the community, the clinic health committees, and the other community structures, they come together as a committee with representatives, youths, and all cadres, all different types of people that are in the population in that community. They have a way of assessing the clinic and identifying the gaps and, discussing, even having quarterly meetings to discuss how are we addressing these gaps, which are barriers to accessing the available facilities, the available health services. So I don't know what is happening in South Africa. I know we are getting more into community, into the community of late. Maybe I would say since 2010, that's when it has really been advocated for. Whilst in other countries, it has been there since maybe in the 1970s. But what is happening in South Africa in that aspect? Is something happening? Are there any tools? Or is it being pirated somewhere? Or, I don't know, but those 2 questions are talking to this same aspect. Thank you so much, over.
Thanks, Dr. Nyasulu. Is there any one of the speakers that wants to go ahead and answer that? Perhaps Lydia, I don't know, you have a bit more experience about.
I don't know if she was going to pop in. So not at a systematic formalized, not in a systematic formalized way. There are some pilots that have been tried. I don't know the details about them because obviously the next step is to use this as a monitoring mechanism for accountability. So it's patchy. I think there are some projects that are trying to establish this kind of monitoring and what it looks like, but it's not widespread in South Africa. I'd be very interested to hear if it's being used across the board in some countries, because that would be an interesting model to learn from. While I'm on, can I quickly respond to Donald's 2 comments, because I think those are interesting. I think I agree that so does the health department want to share authority? I mean, no. So this is why it is a question of power. So it's about first of all utilizing the promised space, which isn't actually there, which is the sort of health committee. So utilizing it and maximizing it, and then also using independent mobilization to make that space meaningful. But this is all about shifting hierarchy and authority, and I don't think that there is a culture of that at all in the Department of Health. And I completely agree with you that with community health workers, it's not just about salary, it's also about status and acknowledgement and space in the system. So if you hear the way community health workers are often treated in health facilities by sometimes doctors and sometimes nursing staff, it's heartbreaking. And just putting them in the system and not doing anything more is not going to change that. So I agree that's a valid point. So we need to change the mechanisms, but know that the mechanism itself is not the solution. It's to open the door, and then we need to get in there and actually use the space to make the change, which is all about power in the end.
Thanks, Lydia. I see, Donald, you've raised your hand, just aware that we are very much at the end of our time, but if you want to go ahead and say something, feel free to unmute.
I'll keep it very, very brief. I've also been working with a different group in Cape Town more recently. Over the COVID period, the Community Action Networks were set up, which were activist structures that ran phenomenal work in these communities and often met high levels of resistance from state, including Department of Health. And Department of Health initiated them and provided them with resources, but also battled them. And so there is an activist network out there that is available at some level, and it's somehow that can feed into the mix. And I realize we're out of time, so I'll close my point.
Thanks, Donald. I appreciate that. And thank you to the three speakers. This has really been phenomenal. I've got a lot of food for thought. I think we've engaged on some really important topics here. So thank you all for your time and for everyone who joined and for the really great questions too. If any of the three speakers have any closing remarks, otherwise I'll hand over to Prof. Chu to do the final wrap up.
Just very quickly, I think we all agree from the audience, our hosts, the chairs and the speakers, this is about power and how we sustain power in this globalised world we find ourselves in. And I can't think of an MPH programme, for example, where we teach what is power and how to create and sustain and share, etc. So maybe when those of us in universities, when we go back to our desk, can think about a module on power in public health. But thank you for the kind invitation.
Yeah, I'll just say thank you very much. I think these types of forums are needed, especially for us in global surgery to learn from each other. I enjoyed both presentations, and I hope that we'll have other opportunities. Actually, I hope we'll create other opportunities to make these type of discussions continue and to learn from each other. So thank you very much.
Just a big thank you,
everyone.
And, I always learn. So thank you to both the speakers and the questions and the comments. Thank you very much.
Yeah. Thank you very much to everyone that participated. Fantastic three speakers, and Lynn, wonderful job moderating. And we look forward to continuing these conversations further. But so much food for thought. Have a wonderful afternoon, everyone. Thanks.
Thank you, everyone.
Thanks, everyone. Bye-bye.
Bye.